Welcome to the 8 Minute Rule podcast, where actual physical therapists share clinical pearls designed to create conversation around what's getting results in the clinic. No fluff, no Medicare stopwatch, only quality content. Welcome back to the 8 Minute Rule. I got Mark and Drew here with me. We're going to go ahead and jump right in. A little bit of a big picture scope question here. We'll just kind of start off with a prompt. So I want to get you guys' thoughts around just a quick question to throw out there. Is it better to treat imperfectly or delay care waiting for the right provider? So we'll let the clock get started here. And Mark, why don't you fire away with your thoughts?
So I think the length of time does matter. I'm talking about I can see this patient Monday and it's like I'm not the best person for them, or this other provider that is the best person for them can see them Friday. Is that an acceptable length of time to make someone potentially wait for the right provider? Maybe. But let's say it's, for the purpose of this, it's more like, okay, it's going to be 2 weeks or maybe even a month before they see the right person. They're able to see that perfect provider for them. I think that in most cases, I can start treating the patient at least, and at minimum, decrease their fears around things, give them some confidence that this is something that is treatable. And, we are, as a profession, moving into this primary care provider for musculoskeletal conditions. So we should at least be able to do a bare minimum for most things. And the patient may not get 100% better with me, and that's okay. But to bridge the gap between when they are going to get to that person that can get them 100% better, I think it's more valuable to start the patient than leave them kind of in limbo where, one, they're still having a lot of symptoms, and they're probably exploring other options, whether that be medications, surgical options, or moving away from the PT profession entirely and seeking other alternative solutions, which could be good, could be bad as well.
Yeah, and I think you brought up a good portion of that, Mark, that a caveat to this question can be within scope of practice, right? We're not necessarily talking about outside of our scope of PT, but things that are in PT scope of practice that you may or may not be familiar with. Drew, got any thoughts?
Yeah. What I heard Mark say is don't let perfect be the barrier to good. So there's been numerous times where I've had somebody ask, oh, can you treat this diagnosis, that diagnosis? And it's definitely not in my wheelhouse. I use an example of one patient who had a lot of ataxia, needed a lot of gait stuff. We're not set up great for a bunch of neuro retraining, stuff like that. But he wanted to come here. There was a self-pay rate. We were better than others. He couldn't afford some of the other places. There was some insurance stuff going on. And, I told him, I said, hey, I might not be the best one around, but I'm going to give you everything I've got. And I researched, talked to some students that I had who were just fresh through neuro stuff, talked to other colleagues, and he did great. And I also think along the way learned, hey, I'm not as bad at this as I think. While it's not my wheelhouse and I'm not hey, I'm an expert, he got significantly better. And one of the things that him and his wife even said was that, we treat him like an athlete, we push him, and he came and would want to work. And because of some of the ataxia stuff, there were things that when he vocally, you would almost guess that there would maybe be some dementia or mental type things going on, but he wasn't. The guy was really sharp when you start talking to him, but I don't think people pushed him enough in order to hit his max gain. So, if you're willing to do the research, someone that you can talk to, and you're going to give that patient all you can, and then also know where your boundaries are, I think don't let perfect be the enemy of good.
Yeah, I think that's great. A phrase there then. We, all three of us, work in a little bit different environments to some degree. And I think this comes down to also have to process through how local healthcare is. If you have tons of specialists around, it could mean more access for patients, but it could also mean that they're waiting 6 months to see somebody. And so, we've had a lot of these scenarios, and pretty much the way I've always acted as a provider is that I want people to get care and get care quickly, because when they don't, they tend to seek more alternative resources that usually have higher consequences to some degree, right? When we're looking at medication, surgery, things like that. So, I to a fault, probably try to take care of people more so, but I do think there's a challenge. We've talked a little bit about concussions, and and that's a hot topic in a lot of circles. But I think you look across healthcare, and it's really a blend of what kind of care people are going to get in terms of where they go. And so I think all of us have seen a lot of patients that have gotten to us who we think probably should have been handled differently. And so the idea is if this person doesn't have another person that's going to be able to give them really quality care in the meantime, can I at least start knowing what better looks like, and then even more importantly, knowing what not getting better and regression looks like. And I think that's a big key to it. Most of the times when I'm working with new grad clinicians is really, what's the worst case scenario that we're looking at? A patient comes in, they're highly irritable, acute, whatever have you. And a lot of new grads are just like, let's refer them. And so the first question is always, okay, well, who have they seen? What's already been done? When you're thinking about what's scaring you right now, what is it? Like, what do you think's going on? Patient's got highly intense neck pain. I'm super irritable. Maybe they have some weakness. Okay, but they've seen primary care, and they've seen a neurologist, and they've had an MRI, and they've had these other things, and it's been going on for 2 weeks. Okay, like if I'm referring, what am I referring for? What am I looking for at this point? What do I at least have awareness of what's going to be the worst thing? Yeah, drop in neurological symptoms. Obviously, we're going to keep track of that, and so I think it's important to really know what the worst thing is in these situations, so that you can have that on your radar for when you need to make sure and refer and bring somebody else in as well too, which is the key piece.
I think if you look at it as an opportunity to learn and get better, that's also a way to, one, help these patients and help you get better as well. Because if you're just scared of it and never see it, you're not, one, going to grow yourself and figure out, hey, how can I help these patients? And I mean, that's how I got into treating TMJ patients, and now that's almost half my caseload, because I was willing to jump in when nobody else was, and I learned a lot. Now I'm way better now than I was a year ago, and I'm hoping to be better in another year versus currently. And so you can continue to learn as you see these patients. And then I think we just put these barriers up sometimes that are unhelpful to patients, and even things like, oh, I have a patient who's in a lot of pain, is really acute and needs a lot, but I only have a 30-minute time slot, but I usually have an hour for evals, and I can't see him, but my schedule's booked up for a week. Like, why not get them in and get started and help, if at minimum, help them navigate where they need to go and get things started, versus having the barrier to, hey, it might not be perfect, but I'm going to do what I can to help you with what I've got available.
Yeah, I think that's a great kind of finishing thought on that as well too. So it's a gray area, and we get to process around it, but being able to look from a bigger scale as to, can we provide some of the best care at the time, and also knowing when we need to refer out as well too. So great stuff, guys. We 8 minutes are up. That was quick, but until next time.